Hello and welcome to another e-learning episode. Today we'll be discussing chronic venous insufficiency, and with us we have Prof Kevin Cassar, Consultant Vascular Surgeon at Mater Dei Hospital, who will be guiding us through the subject. Thank you, Prof Cassar, for being with us here today.
Thank you for the invitation. It's a pleasure to be here. Chronic venous insufficiency is important. It's important first and foremost because of the fact that this is an extremely common problem. In fact, it is one of the commonest reasons for referrals that we receive at Mater Dei. The bulk of referrals are for problems such as varicose veins, venous ulcers, venous skin changes. This is not just in Malta, but of course all over the world. Chronic venous insufficiency is an extremely common problem. The impression amongst a lot of people is that this is a simple, insignificant, minor problem, but nothing could be further from the truth, as we will show you in some of these images. In our experience, we see that there are people who present with fairly extensive ulceration, and often, for various reasons, these patients present sometimes very late. We often see patients referred for the first time who have had ulcers for several years before they actually reach us, and this is possibly one way of raising awareness about this problem and making you aware of what possibilities we have in terms of treatment, new treatment options, and also to show you that if dealt with early especially, and if dealt with well, a lot of these serious problems can be addressed and can be cured. I'll start off first and foremost by taking a look briefly at the cost of this problem. We know, for example, that in this country alone, if we take 25% of the population, which is the estimate of how many people suffer from this problem, we would be looking at something like 70,000 people. So 70,000 people in this country have some degree of venous disease. And that's a staggering number. We do not have figures in terms of costs, but in the UK, for example, they spend about £400 million a year simply on venous disease. I suspect that the proportion would be similar in our country, if not more, because of the fact that, of course, we live in a warmer climate and people are more aware of the problems that this causes. One of the reasons why venous disease is such a problem as well is because of the tendency for ulcers caused by venous disease to be difficult to treat and to be recalcitrant. And therefore, patients tend to suffer with the problem for months, if not years. And as I will show you later on in this presentation, we have means of trying to reduce the suffering of these people. Some basics. What do we need to know to have a better understanding of chronic venous insufficiency? First of all, one important concept is that in the lower limbs we have two sets of veins. We can classify veins broadly into the deep veins and the superficial veins. The bulk of the venous return is through the deep veins. That's the popliteal vein, the femoral vein, the common femoral vein. So over 90% of the venous return is through the deep veins. We then have, of course, the superficial veins. The distinction between deep and superficial is the deep fascia. So anything outside the deep fascia is superficial, anything below the deep fascia is considered deep. In the lower limbs we have two main trunks of superficial veins. Sometimes we call the main one the great saphenous, or sometimes called the long saphenous, and we also have the short saphenous or the small saphenous. The great saphenous is the vein that comes, as you can see on this image, in front of the ankle, behind the knee, and right up into the groin. The short saphenous, on the other hand, is at the back of the calf and comes up from the ankle and dips in the popliteal fossa. The second important principle is that blood in the veins travels upwards. So blood in the veins should always be traveling from the foot towards the heart. A third important principle is that venous blood travels from superficial veins to deep veins and not vice versa. We know, of course, that what directs blood in this direction is valves, both in the deep veins and also in the superficial veins. The two important trunks, which are the great saphenous and the short saphenous, dip through the deep fascia to join the deep vein. So the great saphenous dips through the fascia and the groin to join the common femoral vein at the saphenofemoral junction. And at that junction there is an important valve. The short saphenous, on the other hand, dips through the fascia in the popliteal fossa to join the popliteal vein at the junction which we refer to as the saphenopopliteal vein. These two main valves are often the valves that become defective, or as we explain to patients, become leaky, and therefore blood flow, instead of flowing from superficial to deep, starts to flow from deep to superficial. This is what we refer to as valve incompetence. So an incompetent valve is a valve that is not doing its job right and therefore is allowing blood to flow in the opposite direction in which it is meant to flow. Blood that is leaking backwards in the great saphenous is normally coming from the saphenofemoral junction. So when the saphenofemoral valve is incompetent, you get blood leaking down the great saphenous vein down towards the foot. If the saphenopopliteal valve is incompetent, then you get blood leaking down along the short saphenous vein and again towards the ankle. One other important concept that we need to address is that all of these conditions, incompetence of valves, leads to high venous pressure at the ankle. And it is this high venous pressure, which we refer to as venous hypertension, that is responsible for all the changes that we classically associate with chronic venous insufficiency. The changes that we are all familiar with are first and foremost edema. So as the changes that we've mentioned due to incompetence start to develop, we notice that the ankle normally, or sometimes even the foot, tends to swell. This may be one of the first presentations of chronic venous insufficiency. As time goes on, we sometimes notice that the quality of the skin around the ankle starts to change. These patients start to develop venous eczema, which is characteristically a dry skin with flaking white scales of skin, and which often causes itching. That itching is sometimes then responsible for further trauma to the skin and the eventual development of ulceration. Another very common feature which we see around the ankle associated with chronic venous insufficiency is that dark brown staining called hemosiderin pigmentation. This is again very common in patients who have both superficial venous incompetence and sometimes deep venous incompetence. Ultimately, we tend to see the very chronic changes referred to as lipodermatosclerosis. Lipo is fat, dermato is skin, and sclerosis is hardening or thickening. And what we see in these cases is that the skin around the gaiter area, just above the ankle, becomes hard and thick and becomes very leathery and becomes very different from the rest of the skin. As a result of this, the skin becomes less flexible and more likely to crack, more likely to break, and this paves the way for development of the ultimate stage of chronic venous insufficiency, which is venous ulceration. The vast majority of lower limb ulcers are due to venous disease. Now, one of the things that we ought to mention is that when you see ulcers in the gaiter area, most clinicians would automatically get the impression that this is a venous ulcer. We need to remember that apart from venous ulcers, we also sometimes have mixed arteriovenous ulcers that also occur in that area, in the gaiter area. So the things that we ought to be doing when we see these patients, first and foremost, is to make sure that these patients do not have arterial disease. So when we see these patients, particularly who have skin changes and who have ulcers, it is absolutely essential that we assess the perfusion to the limb. So as clinicians, we all know that the way to assess the blood supply to the limb, of course, is to feel for the peripheral pulses. In the foot, we feel for the dorsalis pedis, and the posterior tibial. The dorsalis pedis is felt in the dorsum of the foot, just lateral to the tendon of the extensor hallucis. The posterior tibial pulse is felt behind the medial malleolus. So it is good practice that with patients who present with venous disease, we always assess the arterial supply. The main reasons for this is twofold. Firstly, most patients who have venous disease should be prescribed stockings, compression stockings. If patients have arterial disease, of course, compression stockings are contraindicated. So it would be negligent of me to prescribe stockings to somebody who has arterial disease. We have seen cases where patients who have not been assessed for arterial disease, who have been presumed to have venous disease and have been prescribed stockings, end up developing a gangrene of the toes. So it is absolutely essential that before we prescribe stockings, we ensure that the blood supply is satisfactory. Somebody with good, strong pulses in the feet is extremely unlikely to have any significant arterial disease. The truth is that in these cases, especially where there might be swelling of the limb and especially of the foot, it may be difficult to feel the pulses. In these situations, we would recommend that handheld Doppler is used to check the waveforms. If the waveforms are normal, that is triphasic, then you can safely prescribe stockings. If you do not have a handheld Doppler or do not have experience with using a handheld Doppler, we have podiatrists in the community who are trained in using handheld Dopplers and who have the equipment who can do that for you and who can assess the blood supply to make sure that the patient has a normal blood supply. Once we've excluded arterial disease, then of course we need to ascertain where the problem is. The first thing that we normally do in this situation is that we ask the patient to stand up. When the patient stands up, the varicose veins become more prominent, and then we can have a better idea of the distribution of the veins. Varicose veins that appear on the medial aspect of the leg or in the medial aspect of the thigh are classically coming normally from the saphenofemoral junction incompetence and through the great saphenous vein. Where there is saphenopopliteal incompetence, varicose veins usually tend to appear in the posterior aspect of the calf. However, the detail of where the source of incompetence is something that the specialist, the vascular surgeon, will determine once he sees them. So if we go back to the situation in general practice, normally the patient will present with one of the symptoms or signs that we've described. Patients may present with the edema and might have noticed that the foot or leg is swollen. Associated with that, the patient might complain of heaviness of the limb. Associated with eczema, the patient may complain of itching. Occasionally, of course, we see complications as a result of varicose veins, such as thrombophlebitis. Thrombophlebitis is classically presents with some swelling, tenderness, pain, erythema, and occasionally hard lumps under the skin where the varicose veins were. Thrombophlebitis is extremely common. One of the common errors is that clinicians assume that because there is inflammation, there is also infection. And most clinicians would treat thrombophlebitis with antibiotics. Thrombophlebitis is not an infective process, but it is an inflammatory process. So where thrombophlebitis occurs, we would recommend that these are treated with non-steroidals if there is no contraindication, and of course with referral for appropriate treatment of the varicosities. Antibiotics have no place in the treatment of thrombophlebitis. Patients will suffer the unnecessary side effects of the antibiotic. Of course, increasing use of antibiotics we know is associated with the increased development of resistance, and they are certainly not doing the patient any good at all. So where there is thrombophlebitis, they do not require antibiotics. Now, we also tend to see very often that patients are referred to us with severe pain in the limbs. Varicose veins and venous disease hardly ever gives severe pain in the legs. What tends to happen is because varicose veins are visible, and therefore any pain in the limb is attributed to the varicose veins. This is something that one needs to be wary about, and when a patient is complaining of severe pain in the limb, there is often another pathology which is responsible for the severe pain. The only time when varicose veins do cause significant pain is when there is associated thrombophlebitis. Now, one of the things that I want to cover in this also is deep vein thrombosis. Now, deep vein thrombosis I bring up only because of the fact that patients who have had deep vein thrombosis in the past are more likely to have chronic changes in the skin associated with chronic venous insufficiency. When we see a patient who has the features that we've already discussed, we might need to ask the question first and foremost whether it is the deep veins or the superficial veins that are responsible for the problem. A patient who has had deep vein thrombosis in the past might have residual deep venous incompetence, and it is the deep veins in this situation that would be responsible for the high venous pressure in the veins and the changes that we've already described. So, in summary, patients with chronic venous changes might have either superficial venous incompetence or deep venous incompetence, or occasionally might have a combination of the two. Of course, these two conditions are treated differently. So, what is the role of the GP when patients present with venous disease? So first and foremost, of course, the role of the GP is to assess the symptoms of the patient. Secondly, is to assess clinically the changes that we've mentioned. Is there eczema? Is there edema? Is there lipodermatosclerosis? Is there presence of ulceration? That is important when these patients are referred, because based on the information that we're provided with, the patient is classified into low risk, intermediate risk, or high risk, and therefore into priorities, whether it is being seen as a routine, as a soon, or as urgent. So patients with ulceration, of course, will be seen urgently. The other role of the GP, of course, in patients who have venous disease is assessing the blood supply and prescribing stockings. The stockings will tend to relieve symptoms as well as delay the development of further complications. The final part, of course, is that the GP can and should, in these situations, prescribe flavonoids, which are phlebotomic drugs, to try and relieve the symptoms, and also, if the patient particularly is willing to undergo procedures for treatment of the venous disease, refer them to the vascular surgeon. Now, what is the role of the vascular surgeon? When we see these patients, again, we will assess them, we'll assess their blood supply by checking their waveforms, but the most important part of the assessment is a venous duplex scan. We have a one-stop vascular clinic, so the patients undergo their venous scan at their first appointment. The purpose of the venous scan is twofold. Firstly, we want to establish whether the deep veins are working well. And by working well, I mean whether they are patent and whether they are competent. In other words, whether there is any thrombosis in the deep veins, and secondly, whether the valves in the veins are working well. The second important question is, are the superficial veins working well? And the superficial veins, as we've mentioned, are the great saphenous and the short saphenous. We want to establish two things. Firstly is the source of incompetence, where the leak is coming from, and secondly, the root of incompetence. Is the reflux coming down the great saphenous? Is it coming down the short saphenous? Is it coming down the accessory great saphenous? And the reason for answering these questions is to determine what sort of treatment is best for the patient. Over the last few years, there have been big strides in the treatment of venous disease, and we are proud to say that in Malta we have practically all of the treatment options available to us. Traditionally, superficial venous disease was treated with open surgery. Everybody is familiar with the high saphenous ligation, stripping, and avulsions. That was the orthodox method of treating these patients. This today is hardly ever used because today we have the availability of minimally invasive techniques. As you will see even in the videos that are attached, we have the option of using radiofrequency ablation or laser ablation, and we also have cyanoacrylate ablation. Radiofrequency ablation is done and can be done easily under local anesthetic. This involves puncture of the vein which is affected, the great saphenous or the short saphenous, under ultrasound guidance, and then passing a fiber into the vein and then burning the vein using radiofrequency. Radiofrequency generates temperatures of 120 degrees, and we slowly burn the vein in lengths of 7 centimeters. The procedure takes about 30 minutes, and after the procedure, the leg of the patient is bandaged up, and we ask the patient to keep the bandage on for 24 hours, and after that to wear a full-length stocking for the next week. Cyanoacrylate glue is a similar procedure, except that instead of using radiofrequency to ablate the vein, we actually use a super glue, if you like, which seals the inside of the vein and stops the reflux of blood down the great saphenous or the short saphenous. Again, this is a procedure that can be done under local anesthetic through a very small puncture under ultrasound control. The big advantage of these two procedures is that even in patients who are relatively frail and elderly and who might have several other comorbidities, these procedures can still be done and the patient can be discharged immediately after. Especially with cyanoacrylate glue, where there is no injection of tumescence, of cold saline around the vein, the patient can literally walk away immediately after the procedure. Indeed, in this situation, we do not even need to bandage the leg up. This is an important development because this allows us to treat more patients, and it is important, of course, for general practitioners to be aware of, because it makes the general practitioner realize that even those patients who might be frail and elderly with multiple comorbidities can be treated, and that treatment, of course, will save the patient the unnecessary morbidity of long-term ulceration, pain, antibiotics, maybe admissions to hospital. Finally, of course, we have another treatment option, which is foam sclerotherapy. Ultrasound-guided foam sclerotherapy involves the injection of a chemical that causes fibrosis and thrombosis of the veins. Part and parcel of this treatment, the patient will develop phlebitis, and it is a chemical phlebitis. Again, these patients do not require antibiotic treatment. When we see these changes, we normally realize that there is, in fact, the effect of the chemical that we're injecting, and when patients do develop these changes, it is indicative that the treatment that we're giving them is actually working. One important issue that I would like to raise here also is that patients with venous disease are often prescribed stockings, but they fail to use the stockings because they are prescribed full-length stockings or tights. In patients with venous disease, the reason for prescribing stockings is to prevent the deterioration of the skin around the ankle. Most of the damage to the skin always occurs around the ankle because that is where the venous pressure is highest. In other words, using below-knee stockings in these cases is sufficient. Patients are usually more compliant with below-knee stockings, especially in our climate, especially in the summer months. And there are, of course, below-knee stockings that are also toeless, and this can improve compliance. One other reason why patients fail to comply with use of stockings is because they're often told that they need to put the stockings on before they get out of bed. This is not necessary, and our advice to patients is when they wake up in the morning They obviously go to the bathroom, and then they can put their leg up and then put their stocking. So it is not necessary for patients to put their stocking on before they get out of bed. In summary, what I'd like to leave you with in terms of key messages is, first and foremost, venous disease is a serious problem. It is associated with very significant comorbidity, and is the commonest reason for referral to our unit, and also the commonest cause of lower limb ulceration. Identifying the cause and treating the cause early significantly reduces the morbidity in these patients, significantly reduces cost, and significantly reduces time lost from work in those who are still working. The second important message is that we have several treatment options. Most of these treatment options can be performed under local anesthetic, and even frail elderly patients can be treated effectively without requiring a general anesthetic as a day case. Thirdly, the other important message is that before prescribing stockings, it is essential that we check the blood supply by checking the pulses, and also, if we have a Doppler available, check the waveforms at the ankles. Ensuring that we have a good blood supply will allow us to prescribe stockings, and also ensure that the patient gets appropriate treatment as early as possible.
Thank you, Professor, for your time and for providing us with a comprehensive overview of chronic venous insufficiency. I trust that through this understanding and through these take-home messages, we will help to further increase your knowledge and awareness on the management of chronic venous insufficiency. And thanks to Professor Cassar, we will also be supplying you with a multiple choice questionnaire which you can complete following this episode to further fulfill your e-learning objectives. I invite you to follow us for further e-learning resources on thesynapse.net/CME. Thank you.